Good afternoon, our dear students of third course. Today we continue our cycle of lectures in propedeutics of internal medicine. And we continue our submodule about signs and symptoms of cardiovascular system diseases. And today we have a new lecture that named Syndrome of Coronary Insufficiency. It will consist of two parts. It will be two lectures, today's lecture, and today we will discuss a little bit in general coronary insufficiency and pay more attention to chronic forms of coronary insufficiency. And topic of our next lecture, it will be acute coronary syndrome. It is two main types of coronary insufficiency. Okay, plan of our today's lecture, it is to give definition to coronary insufficiency, to discuss classification, causes, pathophysiology, and risk factors and diagnostics of coronary insufficiency. Okay, let's give definition. First of all, and here a very important moment, that coronary insufficiency it is a state in which an imbalance occurs between oxygen supply and demand. One more time, it is imbalance between oxygen supply and oxygen demand. Please be attentive that coronary insufficiency and coronary syndromes, it's not a atherosclerotic plaque. It's not an obstruction obligatory of coronary vessel, coronary artery. It is imbalance between supply and demand, and of course most often it caused by atherosclerotic plaque. It caused by narrowing of coronary vessel and abnormal supply, but the opposite, it can be caused by increased demand, for example in hypertrophied heart, where the mass of myocardium is very high. It needs much more oxygen, and resources of coronary blood flow is limited, and it can lead to this relative imbalance and coronary syndrome too. That's why all these terms included in coronary insufficiency. This syndrome prevents adequate maintenance of the metabolic needs of myocardium, this balance resulting in ischemia and several degrees of intensity. Classification, and here are the main point in classification of coronary syndrome. It is two main forms. It is acute form and chronic form. It's not just one form, both of these types. It is a huge group of different disorders, and today we little bit discuss all these disorders. Yes, that acute include main forms. It is unstable angina and myocardium infarction. That can be in two forms too. We will discuss it later. And chronic forms, a lot of different chronic forms. The most often of them exampled here, it is stable angina. Okay, let's discuss syndrome. I told to you that today I connect both as chronic forms as acute forms because they have a lot of general, and it is logical to discuss it in general, but more attention we give to chronic forms. And next lecture it will be some main points about acute forms, and all acute forms in together we name acute coronary syndrome. We divided into unstable angina, I showed you previous slide, and myocardial infarction. Myocardial infarction can be in two forms. It is non-ST segment elevation myocardial infarction and ST segment elevation myocardial infarction, or NSTEMI and STEMI. In more old literature, you can meet such terms like Q-positive and Q-negative myocardial infarctions. It is nearly the same. It depends on size and severity of myocardial infarction, but the elevation of ST segment by researchers it shows that it more specific for size and severity of myocardial infarction. That's why we based our classification not on presence of pathological Q wave on ECG or absence of pathological Q wave. We base it on presence of elevation of ST segment or non-presence of elevation of ST segment. That's why for today it is STEMI, non-STEMI. Mostly STEMI it is Q positive. Mostly it will be transmural. It means that necrosis goes from the endocardium to epicardium through the whole wall of myocardium. And STEMI usually Q negative and usually non-transmural. It means that it's not affect all thickness of myocardium, and usually it can be subepicardial or subendocardial. Okay. Acute coronary syndrome should be distinguished from stable angina, which develops during exertion and resolves at rest. It occurs suddenly, often at rest or with minimal exertion, or at lesser degrees on exertion than that individuals' previous angina or crescendo angina. New onset angina is also considered unstable angina. Chronic coronary insufficiency. The most often we name it stable angina or angina pectoris or just angina. It's all synonyms. It is a sensation of chest pain, pressure or squeezing, often due to ischemia of the heart muscle from obstruction or spasm of coronary arteries. The term derives from the Latin angero, or it means to strangle. Yes, it describes you the most often sense they describe patients with angina. Okay, worsening or crescendo angina attacks. It is sudden onset angina at rest. New onset effort angina and angina lasting more than 15 minutes are symptoms of unstable angina. Most often it's usual for unstable angina. Sudden onset angina at rest and angina lasting more than 15 minutes, usually grouped with similar condition as the acute coronary syndrome. And the most usual classification for angina or angina pectoris or stable angina, like the most often chronic form of angina, it is classification by severity. According to functional classes. We classified by functional classes due to Canadian Cardiovascular Society. And according to this Cardiovascular Society, we have functional classes, functional classification of angina pectoris. It's divided on functional class 1. What is that? It is when ordinary physical activity like walking, climbing or stairs. Sorry, one moment, I have a very emergent Okay, functional class 1. When ordinary physical activity like at walking or climbing stairs does not cause angina. Angina occurs with strenuous, rapid or prolonged exertion at work or recreation. And specific activity it's like ability to ski, playing basketball, jog at nearly it is usual, walking like 5 miles per minute, or shovel snow without angina. Functional class 2. It is slight limitation of ordinary activity. Angina occurs on walking or climbing stairs rapidly, walking uphill, walking or stairs climbing after meal, in cold, in wind, or under emotional stress, or only during the few hours after awakening, when walking more than 2 blocks on level ground, or when climbing more than 1 flight of stairs at a normal pace and in normal conditions. And what usual activity, specific activity, can be without angina? It is ability to garden, rake, roller, skate, walk at 4 miles per minute on level ground, have sexual intercourse without stopping. Okay, next functional class according to severity it is functional class 3. Marked limitation of ordinary physical activity. Angina occurs on walking 1 to 2 blocks on level ground, or climbing 1 flight of stairs at normal pace in normal conditions. Scale by specific activity. It is ability to shower or dress without stopping, walk 2.5 miles per minute per hour, bowl, make a bed, playing golf. Yes, it is lighter activity that can do a specific activity that can do this patient. Okay, causes of angina. Sorry, one moment. It is include atherosclerotic obstructive coronary deficiency or coronary artery disease. It is, as I told you, it is a main cause of this disorder. Second cause, it is cardiac valvular disease. It can be much more rare, but the mostly aortic stenosis. It is the most usual cause of coronary insufficiency. Okay, next it is hypertrophic cardiomyopathy. What I told you about relative imbalance when significant hypertrophy leads to increased demand. Coronary vessels with atherosclerosis, or in some patients even without atherosclerosis, are not able to supply such a lot of oxygen as need this hypertrophic myocardium. Moreover, very often it can be microvasculature diseases like diabetes mellitus and syndrome X. Moreover, it is anomalous origin of coronary arteries and coronary fistulas. Okay, pathophysiology of this process, it consists of 3 fundamental components. Yes, first fundamental components like a first provoking pathophysiological factor of all pathological process. We name it endothelial dysfunction. Endothelial dysfunction, it caused by a lot of different risk factors that we discuss a little bit later, but most of them it is usual risk factors of all cardiovascular disorders. It is family history, it is smoking, obesity, hypertension, abnormal diet, a lot of fat in diet, other concomitant disorders, etc., etc., etc. Endothelial dysfunction, its own step, it leads to obstruction of the lumen of vessels, mostly by atherosclerotic plaque. Yes, when damaged endothelium accumulates cholesterol and provoke growing of atherosclerotic plaque. And if plaque is unstable, it is able to rupture on this place. It can be formation of thrombi, and it can lead to thrombosis of the location of the lesion. It is a cause of acute coronary syndrome. It is the main one of the main things that you should understand, that all chronic forms, they caused mostly by stable plaques that narrow, that grow, that narrow coronary vessel, but not lead to thrombosis. And acute forms, it is always some thrombosis, especially myocardial infarction. It is always thromb that completely obstruct coronary vessels, lead to stopping of blood flow in these vessels, and necrosis, lead to necrosis of myocardium. And one more important moment, the decline of coronary reserve starts when lesion occupy at least 70% of vessel diameter. What it means, when obstruction is by plaque is less than 70%, the patient is asymptomatic at all. Most of these patients live and even doesn't know about presence of atherosclerotic plaque and presence of obstruction, because it is no symptoms. And one more time, by this scheme you can see risk factors of atherosclerosis. They are the same with general cardiovascular risk factors. I will not read everything. Who one can stop on it and walk with all these factors one more time. Okay, clinical picture. It is chest pain or discomfort. Second place, it is shortness of breath. It can be heart failure, irregular heartbeat, nausea, sweating, decreased exercise tolerance, and etc. And I want to stop a little bit on historical moment, how early was diagnosed angina pectoris or stable angina. It was diagnosed by Dr. William Haberden in year 1772. In this year, in his work, he described such syndrome. He wrote, but there a disorder of the breast make with strong and peculiar symptoms, considerable for kind of danger belonging to it, and not extremely rare, which deserves to be mentioned more at length. The seat of it and the sense of strangling and anxiety with which it is attended may make it not improperly be called angina pectoris. Those who are afflicted with it are seized while they are walking, more especially if it is be uphill and soon after eating, with a painful and most disagreeable sensation in the breast, which seems as if would extinguish life, if it were to increase or to continue, but the moment they stand still. All this uneasiness vanishes. In all other respects, the patients are, at the beginning of these disorders, perfectly well. In particular, have no shortness of breath, from which is totally different. Pain is sometimes situated in upper part, sometimes in the middle, sometimes in the bottom of ostomy, and often more inclined to the left and right side, and likewise very frequently extend from the breast to the middle of the left arm. You see how detailed, how and all this description and how detailed, and it looks like real clinical picture of angina pectoris. And from this doctor it goes history of diagnosing of this disorder. And more detailed more detailed description of clinical picture, I want to give you from history too, but it's very good and very actual for today. It is from nomenclature and criteria of diagnosis of diseases of heart and blood vessels of previous century or from year 1953. In this syndrome, the major symptom of thoracic pain, which is precipitated usually by effort but sometimes by excitement, a heavy meal, or exposure to cold. The pain is usually substernal or just to the left of the sternum. Occasionally, the pain is epigastric, and in rare instances, it may be localized in the neck or at the left arm or shoulder. There is a tendency for the pain to radiate, most frequently to the left shoulder and arm, and occasionally to the fingers. Less frequently, it may radiate to the neck, jaw, and teeth, to the back, upper abdomen, or to the right shoulder and arm. At times, the pain will start at one of these points before focusing on the anterior surface or the chest. The intensity varies from slight sense of heaviness or severe crushing pain. Since a precipitating cause is commonly physical exertion, rest usually causes the pain to subside. The length of the episode, therefore, is relatively short. Occasionally, an attack may come while the patient or at rest or even when asleep. The pain is often accompanied by a sense of choking or inability to breathe, in which also relieved by rest. The patient is often complain of flatulence as well. You see how a detailed description, how a good description. And please, I ask for all groups at practical classes one more time. Please work with the characteristics of pain, because if you will be able to characterize correctly the pain, to take correctly anamnesis and detailed complaints of chest pain, 80% of all diagnoses of angina will be in you, even without additional tests. That's why it is all these details is very important moments. If the attack is not relieved by rest or nitrate and lasts an hour or more, and especially if it is accompanied by circulatory collapse, myocardial infarction should be strongly suspected. Occasionally, the pain of myocardial infarction may be identical with the pain of the anginal syndrome. The associated symptomatology and subsequent course will determine the diagnosis. And one more time, clinical picture, all characteristics. Please return to previous slide or read in your books and detail it for yourself. It is substernal pain in the middle or chest, or shifted a little bit to the left, and here showed atypical and atypical places of radiation of chest pain due to angina. And here a scheme of differential diagnosis. Is the chest pain due to cardiac disorders, mostly due to angina pectoris, and how to differentiate from the pleuritic and traumatic pain? And here you have a mnemonic dollar. That means description, onset, location, other signs and symptoms, and relief. And according to all these signs, you can understand why you objectively can differentiate cardiac pain from other types, most often of them pleuritic and traumatic. Okay, on second place in all clinical picture, it goes a shortness of breath. And on this picture, you see a man. For him, typical symptom is shortness of breath. And in some patients, especially with syndrome X and microvascular damaging, it can be even without pain syndrome, and in this case, shortness of breath will be isolated and main symptom of myocardial ischemia. In clinical picture, it can be different tachycardias and different cardiac arrhythmias, as supraventricular as ventricular, and the most danger of them showed on this ACG. We name it ventricular fibrillation. It is arrhythmia that is equivalent of clinical death when productive constriction of heart are stopping. One more typical sign of myocardial ischemia or coronary syndrome, it is nausea, sweating, and diagnosis. How can we confirm the diagnosis? We can confirm it by electrocardiography, by stress test, by echocardiography or heart ultrasound, includes stress echocardiography and intravascular ultrasound. Now I'll show you coronary angiography, radioisotopes, visualization, and blood testing. ACG. Here you see a 12-lead ACG. It is typical ACG, the most standard of ischemic anterolateral ST segment depression in patients with coronary artery disease. And here we really see ST depression, that is sign of chronic forms of stable angina, mostly on the anterolateral wall. And if you pay attention to leads, chest leads, maybe from V2, V2, V3, V4, V5, and yes, a little bit V6. By all this word, we see ST depression that lead of that is sign of ischemia of this region. And here you see different types of arrhythmias. Yes, and here the most dangerous is ventricular arrhythmia that are typical for myocardial ischemia. And it can be in comparison with normal sinus rhythm. It can be bundle branch block as left as right. It can be premature ventricular constriction on third recording. It can be ventricular tachycardia. It can be long QT syndrome that lead to torsado de Pointes arrhythmia, and it can be ventricular fibrillation. Here you see the ACG of real patient with polymorphic ventricular tachycardia that's specific for type torsado de Pointes. At home you can read what is that or detailize in comments in our Facebook. We can discuss with you what is that. Okay, stress test. It is ACG during some stress. Most often it is physical stress. It is veloergometria or running during treadmill test. And here you see by the picture the treadmill test. And here on stress ACG after physical activity, ACG shows ST segment depression. If you see first before stress, first ACG is normal. On second ACG after physical activity we see ST depression. Echocardiography. On this picture we can visualize left main stem coronary artery and proximal segment of left anterior descending coronary artery in color-coded transthoracic Doppler echocardiography. Here it is visualization of coronary arteries too, and it visualizes coronary artery stenosis. The portion of mid-segment of left anterior descending coronary artery with color mosaic. It is sign of high velocity turbulent flow that say you about stenosis. Here it is echocardiography parasternal short axis view, and here we can visualize presence of pericardial effusion. Proximal part of right coronary artery is suspicious for dissection. It's showed by arrow if you pay attention to this wall there. Imaging plane is of axis of non-dilated right coronary artery ostium. Here the picture of contrast echocardiography, upper three pictures in apical 4-chamber, 2-chamber and 3 chambers view, upper panels. demonstrating the extensive reduction of myocardial perfusion on this picture and non-ST segment elevation myocardial infarction patient with angiographic triple vessel disease, including acute occlusion of the right coronary artery and left main stem stenosis. Four-chamber diastolic on the left panels and systolic on the right apical frames at rest to the top, peak at the middle, and post-exercise at the bottom. Imaging in the patient with previous inferior infarction. Rest regional wall motions was normal, whereas apical hypokinesia developed at peak exercise asterisk and had been resolved by the time post-exercise imaging was performed. And here you see examples of intravascular echocardiography. On left it is a normal coronaries, at right it is increased. You see how different they are. Increased coronary intimal thickness, and here thickness is 1.2 millimeters, it is thickened, and suggesting severe vasculopathy of coronary artery. And gold standard of diagnosing of coronary artery disease, it is coronary angiography. It looks like this. It is cardiac catheterization with injecting contrast to the aortic sinus, and contrast goes with all coronary arteries, and by X-ray series X-ray pictures you can visualize all structure of coronary vessels and is it present obstructions or stenosis or spasm and something else. Here on this picture it is cardiac catheterization and coronary angiography that shows severe left anterior descending coronary artery stenosis at the left panel, and it is with stent placement in the left anterior descending coronary artery at right. With a stent it is such a metal device that open lumen of vessel, and you see a revascularization, normalization of blood flow through this coronary artery with removing obstruction. Here it is a single vessel coronary artery disease. Yes, before stenting and after stenting too, you see it was blocks, it not blood flow on the short pieces, and right picture after stenting, after opening and revascularization, it is normalization of blood flow in these arteries. Okay, here coronary angiography too, in case of acute myocardial infarction in picture ABC first, and second admission after revascularization in picture D, E and F. More rare, it not first choice diagnosing, but it's possible to use radioisotope scanning. And it is stress imaging too. It showed by arrow demonstrate inferior lateral and anterolateral by left circumflex ischemia. In some rare cases when it's not understandable something with structure, we can use MRI or magnetic resonance imaging. And here you see ventricular remodeling post-myocardial infarction. Here you can see positron emission tomography. It is one more diagnostic test that can help find you some structural changes, for example, like on this picture, myocardial infarction, and by arrow you see the infarct zone to entire left ventricle myocardium. It looks like this on PET. CT can be used too, and like here it visualizes mild proximal stenosis with expansive remodeling of predominantly non-expansive plaque, and by arrow 2 it showed partially calcified advanced mid and distal stenosis. Here you can see hybrid imaging. Sometimes we use computer tomography and angiography together to visualize and build such 3D models to more detailed diagnosing of coronary artery disease. Here it showed the patient with silent ischemia and by cardiac hybrid imaging integrating single photon emission computer tomography PET with computer tomography coronary angiography. Blood testing. For all patients, we obligatory do lipid profile. It have include completely cholesterol, all its fraction, low density, middle density, high density, very low density, everything, plus triglyceride. Additionally, it can include lipoprotein A. It is additional lipid test that may be used to identify an elevated level of lipoprotein, a modification to LDL-C that increases risk of atherosclerosis. The test may be used in conjunction with routine lipid profile to provide additional information. Additionally to it, we should do patients with suspected coronary insufficiency CPROC reactive protein. It is a marker of inflammation that is associated with atherosclerosis because pathophysiologically, you remember, I hope, that atherosclerosis, it is inflammatory process. The most important blood testing here for coronary artery disease, it is checking for elevation of cardiac enzymes. That's the main thing that help you different acute forms or from chronic forms. More detailed, I'll explain you next lecture on acute coronary syndrome. For today, let's name them. It can be a lot of different cardiac enzymes, but we have several. The most specific for myocardium, it is troponin, myoglobin, and CK-MB or MB fraction of creatine kinase, and all of them in different stages can say us about presence of myocardial infarction. More information on the next lecture. Okay, for today that's all. We have not a very big lecture. I talk a little bit quickly, but if you want to stop on some slides, on some information, you can return. I save this stream on my YouTube channel. You can detailize something, leave your comments and your questions in our Facebook page, and as usual, I ask everyone who listened my lecture, leave your name and group number in comments under the video on YouTube channel. For today that's all, and see you the next lecture on topic acute coronary syndrome.